Those I still get. There we go.
Good afternoon to everyone, and welcome. We'll wait a few minutes to let everyone log on, and then we'll get underway with today's talk.
Do you see at your end as people are coming in?
Yep.
At my end, it shows 20 people, but mostly us.
We'll just wait another minute and then we'll begin. People usually join in through the first couple of minutes. So.
What time is it? Is it 7 hours ahead?
It is 6, which is why we had to change our timing, because Ukraine doesn't change their time, their clocks forward until the end of March.
Oh, okay.
Okay, well, I think we'll begin. Thank you for joining us for today's webinar, Organizing Burn Management Services. My name is Dr. Miroslava Romach. I'm a psychiatrist and co-director of the Ukraine Pediatric Fellowship Program, which is situated at the Hospital for Sick Children, Sick Kids in Toronto, and I'll be acting as moderator for today's session. This webinar series is an initiative of the Ukraine Pediatric Fellowship Program, a program supported by Sick Kids to improve the quality of pediatric healthcare in selected children's hospitals in Ukraine. The series was organized in collaboration with our Ukrainian colleagues as part of our efforts to provide ongoing pediatric physician training while recognizing the difficult circumstances within Ukraine's healthcare system today. Before we begin, I'd like to go over a few housekeeping rules. Today's webinar will be recorded and we will make the recording available on YouTube for those who are unable to attend the lecture live. Live interpretation between English and Ukrainian is available. If you click on the interpretation button located at the bottom of your screen on the right-hand side, you can click the language you'd like to hear. If you wish to hear the interpretation language only, you can click mute original audio. You can ask questions anytime using the Q&A function on your screen, and we do encourage you to do so, please. We'll try to get to as many of the questions as possible today, and for those that we do not, or we are not able to answer, we will send you responses afterwards. You can send your questions to Laura Lewis-Watts. She has posted her email on the chat section. So today is the second of 3 webinars on the fundamental principles of pediatric burn management. Today's session will cover organizing burn management services, and I'm pleased to introduce our speaker today, Dr. Joel Fish. Dr. Fish specializes in burns and complex wound care and is currently the medical director of the burn program at the Hospital for Sick Children. He is a board-certified plastic surgeon and holds the position of full professor in the Department of Surgery, Temerity Faculty of Medicine, University of Toronto. He completed medical school at McMaster University before beginning his training in plastic and reconstructive surgery at the University of Toronto. Following his residency, he completed a traveling burn fellowship program that took him to burn centers in Seattle, Boston, and San Antonio. In 1998, Dr. Fish was appointed medical director of the adult burn program at Sunnybrook Health Sciences Center here in Toronto. And during his time at Sunnybrook, he treated many patients who had experienced electrical injuries and developed a clinical research program focused on understanding how these injuries are related to muscle fatigue, psychological changes, and pain control. Dr. Fish joined the Division of Plastic and Reconstructive Surgery at the Hospital for Sick Children in 2007 and served as the research director of the division from 2007 to 2014. In 2009, he was appointed medical director of the burn program. Sick Kids has the largest pediatric burn program in Canada with 400 to 450 new acute pediatric burn patients treated annually. His clinical practice focuses on the treatment of pediatric burn injuries and includes the full continuum of care from the acute injury, rehabilitation, and secondary reconstruction. In addition, Dr. Fish is a member of the Institute of Medical Sciences at the University of Toronto and supervises several graduate students. He also served as a Royal College examiner for the national board exams, and at present, his research team is focusing on evaluating the effectiveness of laser therapy to improve burn scars in children. Welcome, Dr. Fish, and thank you again for agreeing to provide us and share your knowledge with our group.
Well, thank you for inviting me. I'm going to go to my share screen and make sure that we are. Give me a moment. Hope everybody is seeing this. I'll just get a thumbs up that you're seeing my PowerPoint presentation. Good. So this slide, which shows you a bunch of people with blindfolds on, was put there on purpose because was asked to come and talk to you about pediatric burn care. I think the underlying theme is about trying to improve the pediatric care of burns in your country and trying to do this at a distance. And this is a bit of a disclosure slide for me because there is no possible way. I am blind to the challenges that are faced in your country, both due to the war, resource allocation, etc. And I think it's extremely important that you take the ideas and things that I will present today and maybe feed back to me, not only so that you can learn, but also so that I have an opportunity to learn. We were blessed in December of this year to have Helena Sion come to us and visit our hospital so that she could at least provide us some context of the challenges and the things that are happening in your country with a vision of trying to improve pediatric burn care at a distance, which brings us to today's talk. And she then brought to us 4 areas that she asked me specifically to speak about. They don't necessarily all fit together, and it's a little bit of a stab in the dark. And that's why I started that slide with people with blindfolders on, because I am a little bit blind to that. I hope that this meets the kind of information that you're looking for. And I look forward, and I will tell you now that I am humbled to be offered the opportunity to come and talk. I have more than 3 decades of experience. I have visited many, many burn centers in many different countries, including in North America and outside of that. And it was with that perspective that I tried to pick and choose what I'm going to talk about today. The first and the real challenge in pediatric burns is that pediatric burn patients, pediatrics in general, are not little adults. And pediatric burn patients have very unique needs. Here I have listed just a few of the common things that we know about with pediatric burn patients that are very specific in terms of the way that they are treated. And I will come back to this list at the end of this first little section. One thing that is available to everybody, this still is probably the world's best tome or book available on updated burn care. It is now in its 5th edition. Dr. David Herndon in Galveston, Texas, was an absolute giant in pediatric and adult burn care, but mostly in pediatric burn care. He has brought more medical directors to North America through their program and has trained people from all over the world. And then, in addition to that, has published and brought us a book. So I cannot cover this book, but this is something that is required reading. It should be on the shelf of whether you have an adult or a pediatric center. I bring that to you. I cannot cover that book, of course, in this. So in North America, we have what are called verified burn programs. And the reason that these programs for both adults and pediatric are verified is that it has allowed for improved care. And one of the main elements of allowing this is that the pediatric programs are independent burn programs. They're independent from the other surgical services. They do not sit on the wards with other general surgery patients. And I'm going to present to you some of the data that is already out there that you do not need to reinvent in your country to support the fact that you should have isolated, identifiable burn program. Verification, the whole process of verification, which can be a little bit of a boring topic, but we're going to get through this very quickly, is that a verified burn center. So what are the elements of that make it special, and why would this be useful in Ukraine? And so I thought about this. I am also a verifier for the American Burn Association. So I sit and have extensive knowledge of this process. And our hospital has been verified for 12 years. In order to be verified, you have to have a hospital that buys in and supports pediatric burn care, both in writing and through their resources. You need to have identifiable people in the unit, a burn director, a manager of nursing and rehabilitation, because these are the essential features that drive care. The unit itself needs to be specialized to ensure that you actually can deliver the burn care that's required, and I'll talk a little bit more in detail. And having specialized individuals that are trained in the area is essential. And those 4 items, I mean, the actual verification is a 250-page document. But if you go through and you ask yourself, like, what's the point of doing that? The reason is because patients do better. And then I ask myself, so I'm very used to this, I'm very biased. Would this work in your context? So I would probably say that the last thing you need currently in the children's hospitals where in Ukraine would be more administration. And there is a large administrative piece to this. But I'm not suggesting that you need to be verified. I'm suggesting that you need to have commitment, a commitment to good outcome from pediatric burn cases, and then build a system that works for you in the political system, the healthcare system, and the hospital where you work. But it is getting that buy-in to a commitment that you need to have these isolated units. Now, here I'm going to present you a little bit of information. You can go through the literature and you can find articles that assess and talk about like what happens when burn patients are treated in open units without specialized burn program structure. And so here are but a few things that are well documented. The resuscitation of those patients in the acute phase is always inadequate. The requirements for pain and sedation are not understood and are inadequate, and the outcomes, if pain control in children is poor, is a permanent long-term psychological effect. The nutritional requirements for those children are beyond that which we see in other kinds of hospitals. These are issues that are taken from the literature. Surgical techniques and the timing of when you treat major burns and how to do that require experienced personnel. The nursing care in and of itself as an isolated item can be the difference between life and death in the treatment of pediatric burn patients. The recognition of infection versus contamination, the understanding of the importance of good pain control actually leads to quicker healing of wounds. And this is largely driven through nursing. And one of the final issues, which comes up time and time again in the literature. So when you turn around, I hope after this talk, and go to your hospital and say, you know, this is what we need. The outcome of pediatric burn patients, if you, depending on what you measure, 10% of the outcome is the surgery that's done. 90% of their ability to develop and grow and participate and become young adults is based on the ability to have specific burn rehabilitation. So as with those kinds of ideas that we already know that when you don't have these units, they don't do as well, and you don't need to go out and prove that. This is just one of those studies. And the reason I bring this to you is we're talking about burn management. So like, it's easy for me to say to you, you need to have an isolated unit. But if you have to turn around to the people that you work with and say, like, you know, what is the reason? This is the kind of information that's out there. This is an article that looked and tried to show that there's a relationship between mortality and the number of patients you see. So if you're in a center that does 2 cardiac surgeries a year versus doing 1,000 cardiac surgeries a year, the inference is they always do better where there are more patients. So this was done for burn patients here in North America. What is really interesting in this article and what is so identifiable was that not only was there improved survival and quality of burn care, but it was directly related to having the isolation of burn patients from the general population. The speed of wound closure was quicker when you compared it to other centers. And the other 2 factors was if you were verified or if you had standard operating procedures. So you may not have the administration of a verification standard, but you sat down in your hospital or in your burn program for pediatric children, and you put together some kind of standard operating care, they did better. This is another resource for you. I will not go through all of this resource, but in 2015, and since that time, the American College of Surgeons and in the United States recognized that there were huge issues related to the delivery of care to the pediatric population. And as a result of this, there was a process in 2012, 2013, 14, and this has gone since that time, where they sat down a very broad group of experts, anesthesia, critical care, surgeons, pediatricians, etc. And they went through and came up with a designation and an idea that said, okay, pediatric patients do better when they're in a place where they have optimal resources. And this slide is really just like a summary, because what they found for surgical care in pediatrics is true for pediatric burns. And we at the American Burn Association took this document and incorporated it in what we do. So what did we find from this broad group? All the surgical conditions have better safety and fewer complications. The healthcare providers that were trained in pediatrics were related to better outcomes. And it continued, not only could they show that by separating the surgical care, did you have good care, but that you saw advances in care. So it's with this in mind that not only do you want to build a program that's isolated because the care is better, but it ensures better care for the future. So where would you start? I sat down, I took all of this area, and I said, okay, these are kind of the 4 areas that pediatric burn care is delivered, but it's too much. I don't think it would be reasonable in your situation to be able to tackle all of these things. And I think it is entirely reasonable to look at the fundamental first part of the acute care and sort of isolate those as areas and work on those, and not, I think the mistake is to try to take on too much. Work within the resources that you have. And I would be happy to receive some feedback on this idea, but really isolating and really zoning in on these areas, I think would be one way of looking at it. And I'm going to leave this whole area of burn management and isolated units with this last slide and say to you that if you're trying to organize a pediatric burn program and you want to improve care, there are two essential features. I've relisted all of those things that make children unique. And believe me, if you go into the Dr. Herndon book, the list is even longer. And all of these things require isolated, individualized units. And as part of this process, developing guidelines or standards that are acceptable within the resources that you have at your hospitals, within the resources taking into account that you're in a country that's at war, etc. That would be a reasonable starting place. Now I'm going to move on to an area, again, I put on my blinder because I have not seen and can't say what are the areas of infection control that are going to make a difference at your end. So what I did was I used my experience and I have brought up a couple of very simple issues to talk about that talk about infection control and the kinds of things that I have seen as I've traveled that are things that are easy to change and make a big difference with this particular group of patients. The concept of the isolated units I've already talked about. And so I'm going to try to highlight where improvements are typically required. And I've tried to choose things that are at least cost effective. Antibiotic stewardship. So antibiotic stewardship, or the over and indiscriminate use of antibiotics in burn patients, is nothing but a disaster. All it does is breed multi-resistant organisms sooner, and then we see them in high areas, and it's associated with higher rates of mortality. Areas and hospitals and programs where antibiotics are not used carefully have higher death rates, and they have higher rates of sepsis, and we see this in adults and children. And all it does really is allow for opportunistic infections like fungi to appear earlier, higher rates of graft loss, and the outcomes are quite poor. So just by having stewardship, meaning you give the antibiotic when it's indicated for the appropriate amount of time and do other treatments that are required, not just antibiotics. In burns, there is absolutely no role for prophylactic antibiotics. That practice of starting patients on antibiotics when they come in the early stages, all it has been shown to do in children is to breed multi-resistant organisms sooner. I would not be able to give this talk without addressing the issue of hydrotherapy. I do not know where your hospitals are as it relates to the use of hydrotherapy, but I just need to point out that we have seen time and time again that hydrotherapy is associated with outbreaks, sustained levels of cross-contamination, and in many, many units, they have left these traditional tubs because when the patients are lowered into these and they come out, the entire environment remains contaminated almost forever. So it's always a source for outbreaks. These are the new showers. It's a one-way system where the water enters, the patient is showered, and it exits the room through a separate. And then what is notable in this picture, and I think I highlighted it in this slide, I put an arrow, there is nothing in the room. Nothing at all. So as a patient comes in the room, the supplies enter the room, and then the supplies leave with the patient. And when you are in a resource-limited setting, having shelves stocked with agents, which are then going to become contaminated, this is a very simple step, and it will only happen if it's an isolated unit and not being shared by the other surgical services. This is very simple, this is straightforward, and this is cost effective because once those patients are contaminated, it absolutely spreads to everybody else. We sort of laugh. I use this slide. People say, so what are the special things that you do to keep these burns clean and decontaminate them? And our simple ingredient is simple soap and water. Burns contain dead protein. That is what a burn wound is at the skin level. Skin is made of protein. Heat has been applied. The proteins die. And the simple use of soap and water, and it almost doesn't matter. And soap is available just about anywhere. Washing the wounds with soap and water and whatever else you want, but you do not need expensive ingredients to care for these burns. Small pediatric burns, the simpler the better. We wash them with soap and water. And now I'm going to really go into detail about the dressings and what we use and why. Is that we apply topical dressings that can stay in place for 5 to 7 days. I am going to repeat this next point a number of times, and that is daily dressings in children are a thing in the past. They are not cost effective, they are painful, and they are avoidable. And we have a technique that has been around since the 1980s, which people say is too expensive, but the truth is, in a resource-strapped area, you can't afford not to do this, and I will explain in more detail. All of our children are sedated for pain care. When you sedate them, you can wash and clean them completely. You can completely decontaminate them with just simple soap and water. And then it is at that stage that you can apply a long-acting dressing and it'll stay on. This slide is taken off of the internet. This is a handprint of a small child with Staphylococcus aureus growing in the agar plate. And it is a reminder that how do we transmit bacteria in burn units and in surgical units? It's through the hands of healthcare workers. That includes me and everybody that is on this presentation. I really want to jump into the fact that we as healthcare workers, we are the ones that spread infection. There are a number of things that I've listed here that you can do to try to make it so that you are not adding to that. What are the simple things? You only bring into the room what is required for the patient. Make sure that when you have contaminated patients that they're not in shared rooms. And if they are in shared rooms, this is yet another reason why you need isolated burn programs where there are individual rooms only, because anything else is below standard. Make sure that when you have infected children, that they're done at the end of the day, or that there are not surgeries that are going to go on after. And when you enter the room and there's a child with a multi-resistant infection, whoever goes to the bedside does not leave the bed and does not go out into the room and start to cross-contaminate the rest of everything else that is there. These are behaviors. They have nothing to do with money. It has nothing to do with cost. It all has to do with understanding the principles and understanding what is cost effective. And that is just being disciplined and staying by the patient's side. In addition to this, the basic care, hand washing, and all of these things which you should know about. And Cheris Kelly, our nurse practitioner, is going to go into that in a lot more detail. This is probably the most important part of this entire presentation in terms of, from my perspective, because in our unit in the 1990s, closed dressings were introduced, I'm going to explain, and it changed everything in pediatric burn care. In the late 1980s and the early 1990s, there are ways of treating a burn wound with closed dressings that stay in place for 5 to 7 days that have changed the way we do pediatric care. This slide, leaving the past behind, that is difficult. When you go from unit to unit, as I have, and you see how people practice pediatric burn care, some of it is practiced with science, but a lot of it is just practiced in an apprenticeship system. We do this because this is what we do. But in this era, daily painful dressings for pediatric burn care are a thing of the past. And this, I believe, is an achievable goal, especially in a resource challenged area of the world. So I'm going to talk to you about what happens when you introduce these closed dressings. Cheris is going to tell you how we do these dressings, but I'm just going to introduce to you why it's worthwhile considering this for your unit. What do we mean by closed dressings? Closed dressings, there are many. This is a high scanned photomicrograph of methyl cellulose that is impregnated with silver. There are many different ways of taking basically silver type materials, embedding them into materials and making them available to burn wounds because they have long acting and they're highly efficacious. And a closed dressing is any product which has antimicrobial activity and is intended to stay on the wound for 5 to 7 days. And there are many, many choices all over the world. In Cheris Kelly's talk, she's going to talk about the 2 that we have chosen to use and why. But in your area of the world, you do have many choices. In fact, one of the problems is there are too many choices, and you have to really sit down, look at the products, understand how they're supposed to be used, and use them properly, and then they become financially sound. I'm going to quickly take you through what happened at our institution in the like almost 20 years ago when we introduced this. And what I'm going to show you has been played out time and time again, and I believe could be done in your setting. We have a group of, you choose any kind of long-acting dressing. Doesn't matter what you choose. Many of them have similar properties. And compare it to doing daily dressings, whatever daily dressings are in your institution. And so what did we find? If you compare these 2 groups, these patients are young. We have a very young cohort. A lot of these, if you look at the average burn size, but we also have large burns, but this cohort, a lot of them are small pediatric burns, under 10%, very typical. They occur for the same reasons that you have. We have inpatients and outpatients that we looked at, and the causes of their burns are similar as all over the world, with a high number of these patients having scald burns. And that's very typical for pediatric patients. What did we find when we compared these? So first of all, and most notable, is when you, I'm going to, skip to, there's not. When we looked at the number of dressings that the patients were getting in these 2 groups, all of a sudden, of course, because you're putting the dressing on and keeping it, but if you looked at the total group of patients, this and the nursing and the costs of being able to do daily dressings fell dramatically in this group of patients. In addition to that, when we looked at the patients and compared to a historical group, we had a whole group of patients who either gained weight, did not need feeding tubes, the vast majority of them, compared to a cohort where we actually used to have patients that were losing weight and needed to stay in hospital. We would compare this to the old group, and we basically almost eliminated the need for feeding tubes in many of these patients. One of the criticisms that's made about these closed dressings for when you do them inside the hospital is when they go home, are you then going to have the need for more care? And in our setting, it was not true. When they left the hospital, they still required fewer dressings than the children that were getting daily dressing changes. And remember, daily dressing changes are painful. We don't need to study that. We also know that daily dressing changes require a lot of nursing care, which is extremely expensive. What else did we find? Well, the patients in our setting, most of them, 70% of them, were out of the hospital within 3 days. And all of a sudden, our burn unit, where we had historic numbers where almost everybody, 80 to 90% of the patients, stayed greater than 10 days. So if you can imagine the resource positive effect that it would have by allowing these patients to be home in their own beds, eating their own food with their parents. 94% of them were staying in the hospital more than 10 days. If you just looked at those that had surgery, the numbers were equally favorable. 85% of the patients used to stay, without surgery, they would stay even a lot longer. This is just a snapshot at the early time, the 4 years after we introduced this. Now, since this time, our census has grown to 400 to 450 a year. These were in the early years when I had just started here. And if you look at all of these patients in this program, and what I really want to show you is not only, this shows you the length of stay, not only did you half it and they went home a lot earlier, but these are Canadian costs. And it's just to give you an idea that the cost per patient in 2009, before we introduced expensive dressings, so people will always tell you that these dressings are expensive. The moment we introduce these quote unquote expensive dressings, the cost per patient fell for 4 years to the point that you don't even need statistics to tell you that the cost savings of these expensive dressings more than pay for themselves. And this kind of data is out there, and you do not need to reinvent this. You just need to you need to get the commitment, and you need to get the hospital to buy in that this is a cost-effective way to treat children. Sorry, I just have to catch up on my slides here. So closed dressings decrease the length of stay, fewer dressing changes, fewer needs for anesthetics because you're doing them only once a week. And we almost eliminated the use of feeding tubes. And this, I hope, will lead to this, which is daily painful dressings, being a thing of the past. This is a very, very important thing. And it is something that is the nurses in particular who are providing this care, once you start to introduce such a technique and sedate these children, that it changes the entire program and it changes the outcome for those children. I'm now going to switch gears a little bit into a much more technical area. And I was asked to speak about surgical strategies to reduce blood loss during burn surgery. I was almost a bit puzzled because this and these techniques have been available for 20 years. And it still amazes me from time to time that I will go to places and that they will not utilize these techniques because they are easy to learn, readily transportable. But I am happy to cover this here. It was one of the topics that was felt to be vital for me to cover. When you're talking about blood conservation, the clinical problems are that blood banks have limited resources. And I can imagine that in your country at the moment, that access to blood and blood products is limited. We had an investigation in Canada of our blood services in order to make it safe. So at the time when this was introduced more than 20 years ago, we were also concerned about passage of infectious diseases, which is no longer an issue. And there are significant risks related to transfusion. There are significant risks of lung injury related to transfusion. And so the clinical problem of trying to limit blood loss during burn surgery has been around for decades. And historic numbers, which would show that cross and typing using up to a unit of blood for 2% body surface area, these are numbers that are in the historical literature, which have all but been eliminated. There are many different kinds of blood conservation strategies. We use a subcutaneous infiltration of a very dilute adrenaline in the children. We also use topical nonstick pads with topical adrenaline. And where needed in the extremities, we will use tourniquets that can be applied so that tangential excision can be done in a near bloodless manner. Now, I'm not going to go through all of the literature that was published in this area, but there's lots of literature. This was published in 2001. It really goes back. And what happened was when we introduced blood-saving techniques for burns, the rates of take of the skin grafts went way up. The transfusion rates dropped by 50%. And the use of additional blood products, which are hard to come by, factors, platelets, plasma, FFP, etc., were almost eliminated compared to historical cohorts. We further looked at this in our burn program. This was authored by Dr. Rob Cartato from Toronto. He's the current president of the American Burn Association this year. And we went through, and when you introduce these techniques, we now reduced the need for blood to as low as 0.15 unit per % body surface area burn. That is a huge reduction and a huge increase in the safety for these patients. This was a design where we went back and looked at it prospectively. I'm not going to bore you with this, but it is very important. This was done along with our anesthesia colleagues, and we were able to conclude that blood conservation techniques in our place, similar to other places in North America and Europe, are easily applied, resulting in significant reductions in blood loss and transfusion requirements. And I have some pictures to show you what we do. What always gets talked about, and when I switched from the adult burn unit to the children's burn unit and started to practice here at the Hospital for Sick Children, is this article talking about the cardiovascular effects of infiltrating large amounts of subcutaneous topical epinephrine. The bottom line is that it is 100% safe. We actually sat down and did a study looking at the acute cardiovascular response in a whole group of patients that were being put to sleep. And we were able to show that there was no increase in, aside from the fact that the mean arterial pressure transiently increased, that was not related to where you injected. It did not require any type of care. It was not related to any anatomic area, and it required nothing in terms of clinical management. And so it was safe. It had minimal, if any, effects at all. This technique has been shown and transported to numerous parts of the world, particularly in areas of the world where blood is not available. Rates of malnutrition and nutrition-induced anemia in children are rife. And it's with that in mind that I would say to you that those of you who may practice burn surgery, the use of blood conservation techniques are standard, are easy to learn, and something that will improve the care, particularly in children and in adults. This is the technique for those of you that are not as familiar. I have a video which I was a little bit worried to use, but this is just the infiltration into a donor site. This is the donor site. These are old slides. This is an adult when I was up at the adult unit, but it's just to demonstrate. This is the harvesting of a skin graft. And it's only at the very end here where we would have infiltrated the area that you see a small blush of blood, but donor sites are harvested routinely in our children, their entire back and both legs, with never even a drop of blood being transfused. I want to introduce to you what are called the 3 Ps of the technique of when you're using what is called the tumescent technique. Assessing the burn wound for tangential debridement is easy, but it needs to be taught, and we teach this to our students. There is a video that if you were to email me, I would share with you. We look for pale yellow fat, pearly white dermis, and patent subdermal vessels. And these 3 Ps, if they're intact, show you that you have surgically gone deep enough. So here we are now, we're infiltrating an area of the burn. This is, I believe, on the abdomen. This is after the first swipe of a tangential excision. And what you can see here is the red stained dermis, which needs to come. It is not pearly white dermis. In an almost near bloodless field, you can see now that there is fat that is stained that needs to come off. And then eventually we get to the point where we have a visible subdermal vessel, pearly white dermis, pale yellow fat, the 3 Ps, and our tangential debridement using a technique of subcutaneous infiltration with adrenaline, making it very safe and very low rates of transfusion. So this blood conservation technique improves outcomes when there's limited blood supply, children are malnourished, I've mentioned that to you, and maximizes intraoperative safety. The last thing that I want to tell you is that this technique of tumescing the tissues in children has changed the way that we operate on our children. And our actual surgical technique that we use is a totally other talk. I do not have enough time to finish that here today, but just merely to share with you the fact that when you use these tumescent techniques, it improves the harvesting of sheet grafts in children. We only harvest sheet grafts. We rarely ever will leave a child with meshed skin grafts because of the cosmetic outcome is poor. It allows us for taking skin in areas over bony prominences by being able to tumesce the skin. Curved surfaces, very easy to teach. This is a typical child about 2.5 days later. These were deep burns. We waited around 10 days. We have a 2-step technique we use. These are the sheets of skin that have been applied to this young boy. And here he is about a year later with what would be an average outcome for us. I'm going to stop this talk. Then I put this slide in, and why did I include something that says, I have not failed, but I've just found 10,000 ways that won't work. It is really my hope that if I failed during this talk, to really reach and explain the issues, because I am blind to what is happening in your country. I cannot possibly understand the impacts of the war, the resources, the children, healthcare workers, etc. So if for some reason I have failed, it's not because I have not tried. And my only hope is that you'll invite me back, and that those of you that are out there that practice in this area will reach out to me. We'll be able to give you my email, help you with cases, and maybe come back to the seminar with very specific areas that you think I might be able to talk about, and possibly we can share. I'm really just trying to open the door to new ideas, and I very, very much do not feel I should ever, and if I apologize if I've ever come off as telling you what to do. That is not my intention. I have lots of experience, and I have been to many, many parts of the world, and I tried to put together today a program of things that I hope would jog some ideas and share this with you. So it's with that in mind that I will end. I'm going to stop sharing my screen and say thank you.
Thank you, Joel, for an absolutely fantastic presentation. We'll now proceed to the question and answer section, and Dr. Zoriana Ivanyuk will do the translation, although I see that some of them are in English, but here we go. Zoriana?
Дякую вам дуже, доктор, за
Thank you very much, Dr. Fish, for an incredibly interesting lecture. We have many questions coming. The first question, thank you for an interesting lecture. Please tell me, how many nurses do you have in the unit? And do you have this practice of having one nurse per patient? Or what is the correlation?
We have a lot fewer people than you would ever imagine. So our burn program, all of the burn patients are on a ward with the plastic surgery patients, but about half of the ward are always burn patients, and burn patients are a priority. They never go to other floors. So we have 2 nurse practitioners who specialize in burns. One of them you are going to speak to, Cheris Kelly. She has 20 years of pediatric experience. We have someone that we've hired. And so the plastic surgery nurses all have added training and extra education in burns because they are isolated in that area. So that's one. The other thing is that when our patients go to the pediatric intensive care unit, which is maybe 8 to 12 times a year, it's not that often, we do a lot of education with the pediatric ICU, but our nurses wind up going down there. So how many nurses do we have? Do we have one-to-one? Rarely on the floor do we have to have one-to-one nursing. Sometimes when we have a burn patient that's particularly unwell, we do allow for one-to-one. Also, because they might have multi-resistant organisms or carrying bacteria that we don't want to spread, we often they're all individual rooms, and often those nurses are not shared with other patients in order to limit the spread of infection.
Дякую дуже. Наступне запитання.
Thank you very much. Next question. Do you use xenograft? And how often do you change the dressing above xenograft?
Okay, sorry, if you could just repeat the question.
Do you use xenograft? How often do you change dressing above xenograft?
Okay, so xenograft typically in the world at the moment would be pigskin is the most common xenograft that's used because it's readily available, and also fish skin. Fish skin is another xenograft that is there. We don't use this for a number of reasons, because although in some areas it will help, it does not vascularize. We use allograft as opposed to xenograft. So we use human cadaver skin. We surgically, when we know that the wound is deep, we surgically debride the wound. We place the allograft, the dressing goes on, the dressing stays for a week. We do not do awake routine dressings. It would be very rare either for a burn wound that's healing, a skin graft, a xenograft, or an allograft to do a dressing more often than once a week because of the use of these closed dressings. And also the children are sedated for these dressings so that they're not in pain. So our care model is very different than what you will see, but we consider pain management the #1 vital sign in the children. number one vital sign, because it is the only thing that the parents and the children will remember 70 years after a burn. If you ask them anything about their burn care, the only thing they'll remember is the pain. They won't remember anything else. And that is well documented.
Дякую дуже. І наступне запитання. Як ви захищаєте пов'язки від сечі? Я так
Next
розумію.
question, how do you protect the dressing from urine? As far as I understand, this is when the burns are in the area of the lower extremities. So how do you protect dressing from urine?
Okay, so in children, any burn that's in the perineal area is always at risk. So if the child's in a diaper or nearly out of a diaper or immobile, right, and not able to do that. So typically what we'll do is the inner, we'll do a couple things that are simple. One, sometimes we just leave those areas exposed. We'll apply a simple nonstick dressing that can be changed with the diaper, so that as they're soiling their diaper, the diaper's changed, not the dressings. If we also provide enough outers on the dressing, outer layers, that they can be trimmed. And sometimes if we have to go back a little bit earlier to change those, we will. I will tell you that there is nowhere in the world that has yet come up with a perfect solution for children with perineal burns to keep those areas clean, to keep off the urine, to keep off the feces. We struggle similar to you. And all I can say is that it requires a lot of nursing care. And it's yet another reason why, if you're going to have a child with a burn in those areas, they need to be in a specialized unit so they know how to handle that. Urine is much less of a problem for us, just because we can usually fashion the diapers so that they're not wetting the area. It's usually more the soiling from feces is an issue. And you may not have asked this, but we avoid as much as possible. Aside from in the acute injury where they're really immobile, we will put in a Foley catheter, but we try to get them out as soon as possible so that they can get up and walk and get to the toilet. We also don't immobilize the children after we graft them. After they're grafted, we are very quick to get them up so they're allowed up to the chair, allowed to get to the bathroom. They do not need to be immobile lying in the bed, and that also helps in that situation.
Ще одне питання в нас. Чи ви
Another
фіксуєте
question,
графти на донорській
do you fix the skin grafts on the donor sides?
Okay, I'm just going to repeat the question to make sure I have it.
Чи ви використовуєте метод
Do you
фіксації
use the method of fixing of skin grafts on the side, on the recipient side?
Oh, what technique do we use to fix grafts in place? I believe that's the question.
Так.
So,
Correct.
so for the most part, for the larger areas, we will staple them into place because it's quick and easy. For areas that are very uncomfortable and when they're small, we will suture them on with a non-absorbable suture and then take it out and sedate them later and take it out. Areas of the face, areas of the hands, areas of the genitals, areas of the feet, the staples in little children are just too big. Flat areas of the chest, flat areas of the back, and sometimes the limbs, staples and sutures are equivalent, and the staples are much quicker. So we've used them quite successfully, but we tend to staple them. And if we think it's a smaller area and requires a little bit more skill, we'll then go back and suture some area and remove the staples. I will tell you, though, that the technique, we only use sheet grafts. So our grafts are continuous, like this piece of paper. They are not meshed. And so with that, the care that the grafts need to be placed on requires training and requires a bit more expertise than a lot of people appreciate in their training.
Дякуємо дуже. Наступне запитання.
Thank you very much. Next question. Usually, when we use the Aquacel Argentum silver dressings, the wounds look a lot more dried. So what do you think about the hydrocolloidal dressing instead?
So we started using them, but that we just felt there were other products that were the same cost and a little bit easier to use. Just like every product, as long as you understand how it works, then you can decide whether it's good for your system. Some of the products like Aquacel AG and hydrocolloids, which absorb the fluids, they need to be removed often a little bit sooner than a week because they get, I have pictures of how it looks, and it could be something in a future seminar. We found it a little bit harder to manage, and also the healthcare providers found it a little bit more confusing because you can't really evaluate the wound as well. There's nothing wrong with them as long as they're being used properly. They generally don't last a full week. They generally last more around 5 days, which is why we moved to other products which really last a full week or even longer. It gave us a little bit more leeway in terms of organizing them. Are hydrocolloids better than what we do, or is it better what we do compared to that? I don't think that's the issue. It's what works in your system and where you are. And that's what would make me decide whether I chose to stick with a hydrocolloid.
Дякую дуже. Наступне
Thank
питання
you.
стосується
Next
застосунку.
question is about the administration of epinephrine.
Чим ви покриваєте, власне,
What do you use to cover the burn area after the epinephrine stops working? Do you inject only saline and epinephrine, or what do you think about the tranexamic acid as the topical application?
So we rarely need to use tranexamic acid because it's a platelet stabilizer, totally different. But the subcutaneous adrenaline, because the bleeding in the dermis or in the subdermal layers are small vessels, they'll vasoconstrict, but they still do bleed. And so you really, I mean, I didn't do full justice to the technique in the slides. I sort of left it at a very simple level. But once you take the layer off, we actually take a syringe with fluid and we drip it on the wound and we sit there and cauterize every little tiny blood vessel. But it's very easy to see. And the technique of dripping the water, you actually can see the little rivulet. And so we just stop it, we hemostasis, and just put our grafts on, and that's it. We also do use topical, what is it called? Artiste, which is for sheet grafts. Sometimes we use that if we're concerned. But we are very meticulous with the hemostasis and make sure that the bleeding is stopped before we apply whatever we're applying. Once you see the technique in action and you come and you actually can see these little tiny vessels that will bleed after the adrenaline wears off, and rarely is it an issue. Our rates of graft loss, we just finished a study where we measured graft loss in about 200 cases, about 80 surgical cases over a period of about a year and a half. Our graft loss rate is less than 1%. Less than 1%. We do not keep the children in hospital. We fix them in place and let them go home. Hematomas, and which is what we're talking about here. We had 4 children in 4 cases in 250 operations, and those were in 3 children who were older teenagers who left the hospital and went off on a bit of a binge. It may not be our regular care. So this technique is safe. They rarely bleed if you're careful and taught how to do it properly. It is a topic that's really almost a whole entire other seminar.
Супер, дякую. І ще одне
Thank you
питання.
very much. Another question. Do you use the NPWT after applying the perforated grafts? NPWT after you use the perforated grafts, do you use NPWT? This is
Just say
the
it again.
meshed grafts. Do you use the NPWT devices after the vacuum? I mean, after
Oh,
you use the meshed graft.
negative pressure wound therapy. Okay, negative pressure wound therapy. So no, we don't. There are people that do that. Again, how you want to fix a graft, there are many different ways of doing it. When they have been shown to work, we're able to just put dressings on and have them work equally well. It allows us to send the children home. So in our area, if you put a vac on a child or negative pressure wound therapy, it means they're going to stay in the hospital, or it's going to be very difficult to send them home, because similar to where you are, we treat patients that travel huge distances to come to our burn center. Now, we don't have a war, so it's easier to travel, but it's very difficult travel. And so we tend not to use it. People do use it successfully, and the outcomes are good. The other thing about it is you have to be very careful with negative pressure wound therapy near your donor sites, because sometimes it can lead to excessive bleeding because of the negative pressure. But it is definitely a technique. We tend not to use it because we have other simpler techniques that are just as effective.
Okay, we're going to have to start to wind up here, but two last questions. Joel, would you be willing to share your presentation for distribution to other doctors?
Oh yeah, of course.
Okay, so we can turn, Laura Watts can be contacted for that. And also, one person is asking if they can connect with you for asking some questions about situations in their hospital. Would you be willing to be?
Yeah, I was actually, you know what, on my last slide, and I meant to do this last night, I was going to put my email up. And I think you could send out my email in the chat, just joel.fish@sickkids.ca. I would encourage you, if you have cases, you can send them to me. It is a hospital, it's a private email. I'm happy to receive cases. Some people have tried to connect through WhatsApp. I don't use WhatsApp because I just have too many electronic connections and I can't get to it. I am happy to share my email, and I am happy to try to help you with cases. Pediatric burns are tricky. Pediatric burns can have horrible outcomes and that are avoidable. And it is really, I also have a group of people that I reach out to in North America when I have problems as well. So being part of that is always useful. It's always helpful to hear from other people.
Okay, well, thank you once again, Joel, for an excellent presentation. I'm sure it was very helpful to our listeners. We'll be posting all of our webinars onto a YouTube channel. To view or subscribe to the channel, you can click on the link that Laura has put into the chat box. Yes, and you can ask some questions that we didn't get to or that you may come up with afterwards, and you can send them to Laura and we'll try to respond.
Yeah, just send them my way. Happy to. Thank you for giving me the opportunity. This is a challenging way to do education, but I think that it is more than, for me, it's like a sense of humility. Like, I'm really happy that you invited me, and I thank you again. I really
We're
do.
very appreciative. Thank you.
Okay.
So our final session of this webinar series will be held in an hour's time at 1600 hours Kyiv time. This talk will be led by nurse practitioner Therese Kelly on principles of nursing education in burn management. If you haven't already registered, there's still time to do so. You can click on the link provided in the chat, or you can click on the QR code in this slide. Thank you to each of you for joining us today. Thank you, Dr. Fish. Thank you, Dr. Ivanyuk. Thank you, Laura Watts. Together, we'll continue to strive towards improving pediatric healthcare and making a positive impact on the lives of young patients in Ukraine. And we hope to see you at the next session. Дякую.